Good evening, everybody. Good evening. And thank you for joining us. My name is Brad Snitzer, and I'm the chair of the Professional Society, along with the vice chair of the Healthcare Division, Dr. Denise Meckler. It's our honor to welcome you here tonight. Our program tonight is brought to you by the Healthcare Division of the Professional Society. The Professional Society is a giving society made up of donors in the financial, legal, healthcare, business, and real estate fields. And I'd like to thank our Professional Society members for their continued participation. And for those that are not members of the professional societies, I would encourage you to become a member by increasing your annual gift to $1,800 or more. We provide programs of interest to you, our donors, and hope that through these programs we can introduce our guests, not yet familiar with the work of the Federation, to the important role we play in the community. Throughout the enormous challenges of the past few years, and with the support of donors, many like you, our community has stayed strong and connected, while also helping those in need here at home, in Israel, and worldwide. In 2023, the Federation raised $8.76 million from 3,000 plus donors in our community, $4.3 million for Israel through our Israel Emergency Fund, and in total we raised over $17 million for Jewish life in St. Louis, Israel, and around the world.
Professional Society is great about connecting professionals in various industries in our Jewish community. It's a valuable network and is good for networking, as well as learning more about the good work and the impact of Jewish Federation. When we started meeting as a committee several months ago for tonight's event, it became obviously clear that the topic of the reproductive health care is one of the most important topics that the field of healthcare is currently facing. And it doesn't matter what gender one is, this information is pertinent to everyone. All of us, we each have a partner, a coworker, a daughter, a friend, and relatives that are affected by decisions that are being made. One of the roles we play at Federation is having the unique ability to bring together all parts of our community, all of you, all of our panel, in situations like tonight's event. It's my pleasure now to introduce my co-chairs, Patty Krugen and Sarah Mermelstein.
Brad and Denise, thank you so much for your leadership and for hosting us tonight and welcoming this event. Our program tonight is focusing on the important topics of reproductive health care, as Denise said. We've assembled this amazing panel of experts and our moderator, who are experts in their respective fields, along with rabbis from various branches of Judaism, to help us understand the current challenges to reproductive health care and what's currently at stake. Today, June 24th, marks exactly 2 years since the Dobbs decision, which overturned Roe v. Wade and removed the constitutional right to abortion. During our panel discussion this evening, we'll hear more from Drs. David Eisenberg and Dr. Jennifer Smith and about how this landmark decision has changed the day-to-day practice of medicine and the field more globally, from medical recruitment to patient safety. We will also hear from Rabbis Fader, Arno, and Smason about the Jewish perspective on these important issues and how the Jewish community is experiencing and interpreting these many rapid changes around us. We want to take this moment to acknowledge that we recognize that these topics are intensely personal for so many people in our community and in this audience. Firsthand experiences with pregnancy loss, termination, infertility, and the spectrum of reproductive health issues that may be discussed tonight will almost universally impact you or someone that you love. We've worked very hard to create a discussion that is safe and supportive for everyone this evening. The Jewish Federation of St. Louis serves the Jewish community based on the core value of Klal Yisrael, Jewish peoplehood. The Federation strives every day to care for Jews in need and celebrates the diversity of beliefs and practices in our community. At the core of our Jewish community is the knowledge that we mean something to each other. Conversation is at the heart of Jewish life. We study, discuss, and use our passion to engage with each other. As a community, we embrace our differences and are inspired by our commonalities through engagement and education. Before we introduce our panel, I'd like to thank our incredible event committee for their expertise in helping us plan tonight's event. Please stand, those of you who are here tonight, so that you can be recognized. Your input and knowledge and support is so appreciated. We would also like to acknowledge a last-minute change in our original program. We were extremely fortunate to have former Missouri State Senator Jill Shoup agree to be our moderator this evening. And Senator Shoup worked for many hours to connect with our committee and come up with questions and ways to really get our panelists involved and to stimulate an amazing conversation this evening. And we know that because of her efforts, we will still have an incredibly dynamic conversation. However, unfortunately, Senator Shoup actually tested positive for COVID this morning and let us know that she wanted to make sure she was acting in the best interest of everyone in the room, and unfortunately was not able to join us. So I wanted to just take a moment to recognize her, thank her for her efforts, and send speedy wishes of recovery and health to her, but much gratitude as well. So can we thank Senator Shoup? Thank you. So we made some very last-minute adjustments, obviously, to a huge portion of our program this evening, and my co-chair, Patty Krogan, was amazing and volunteered to step into the moderator position. Patty is a retired mental health provider with decades of experience working with women and children in our community, and is also a former Jewish Federation board chair. So she is no stranger to facilitating a room of passionate voices, and we are so thrilled and grateful that she's able to step in for Senator Shoup. So with that, I would say we would like to welcome Patty to the stage, and we'll get the program started. Thank you.
I've always wanted to be an understudy. Thank you, Sarah, and good evening to everyone. We are delighted to see so many members of our community come together for this evening. During those years, those decades of practice, actually 50 years, I treated individuals and couples, many of whom faced very complicated and difficult reproductive and conception issues. My volunteer life has primarily focused on the needs of the Jewish community, first as board president of Congregation Sher Emeth many years ago, and more recently as the board chair of the Federation. I currently lead support groups for widows, a program created by our local National Council of Jewish Women. Tonight, we gather to learn from an exceptional group of experts who will share their perspectives, knowledge, expertise, and experiences. I'll briefly introduce each panelist as they are invited to speak, and their more extensive bios are included in your programs. Our hope is that you will find this evening educational, and that after tonight, you will feel encouraged to have thoughtful discussions with those around you. Our questions tonight will cover 3 areas. 1, the current state of reproductive health care. 2, the law and its impact on physicians and patients. And 3, Jewish perspectives on reproductive health care. Each panelist, now you won't believe this one, will have exactly 1.5 minutes to answer their questions, which have been provided to them in advance. When appropriate, I may pose follow-up questions. And I have to admit publicly that I'm very comfortable, having grown up in a medical family, in interrupting doctors. I am not at all comfortable interrupting rabbis. But we hope to also have time for your questions before we close. Please write them down as you think of them on the cards provided in the programs, and pass them to the end of the aisle. One of our staff folks will pick them up and bring them to us. So my first set of questions is for Dr. David Eisenberg. Dr. Eisenberg, in addition to being a doctor, is also a master's of public health, a professor and director of Division of the Complex Family Planning at Washington University in St. Louis, Department of Obstetrics and Gynecology. He is also the program director for their Complex Family Planning Fellowship, which hosts OBGYN resident graduates to spend 2 additional years training to become experts in contraception, abortion, sexual, and reproductive treatments. So, Dr. Eisenberg, as Sarah said, it's been 2 years exactly. This is the anniversary of the Dobbs decision. What has changed since Dobbs?
Thank you for the opportunity to participate and to get to reconnect with so many people who I haven't had a chance to see in a while. I will say that so much has changed, but so little has as well. So I've been here at the medical campus at WashU since 2009. The process of providing care for people who need to end their pregnancy was already a real, like a post-Roe reality by 2019, to be honest. The screws had been tightened by the legislature and the state health department and other executive branch, parts of the executive branch in terms of regulatory prohibitions and layers of challenge to be able to provide essential health care, that we were used to what is a medical emergency, and I know we'll speak to that. We were used to when do we waive the 72-hour consent requirement that was the same physician with no exception. We understood the processes that would have to be brought into place in a post-Roe reality really well from 2019 on. So when 2022 came, which was not a surprise to me 2 years ago today, it didn't change a ton for me as a provider. If anything, it waived the 72-hour waiting period in the state of Missouri. Everything's a medical emergency if I do an abortion in the state of Missouri. And I still do. The number of abortions that I've done for medical emergencies on an annual basis for the last 2 years hasn't changed. The number of patients who we care for at the medical campus has reduced by about 1/3. Primarily, it's the people who are having lethal or life-limiting fetal anomalies, where thankfully nothing is wrong with the mother of the pregnancy, but the pregnancy itself is a futile approach or futile endeavor. And the choice to end that pregnancy, which many people make out of love, is one they have to take with them out of state. And that's the big change that has happened.
That was amazing.
The clock in the back is helpful. I need one of those when I'm talking to patients.
So you've begun to answer this question, but it is, can you give us more of a sense of your decision-making process, how it works under current Missouri law, given that the law states that no abortion shall be performed or induced upon a woman except in cases of medical emergency? And you went on to share with us the definition. Would you like me to do that?
If you wouldn't mind reading, I'd like everyone to listen. This language around medical emergency did not change with the Supreme Court decision 2 years ago. This language around medical emergency has been on the books in the state for years. And really what it governed was when we could waive that same physician, no exception, state-mandated propaganda-like consent process that had to be done for every person choosing abortion. And we were used to when we could waive that 72 hours based on this medical emergency language.
So medical emergency is defined as a condition which, based on reasonable medical judgment, so complicates the medical condition of a pregnant woman as to necessitate the immediate abortion of her pregnancy to avert the death of the pregnant woman, or for which a delay will create a serious risk of substantial and irreversible physical impairment of a major bodily function of the pregnant woman.
And some version of this language has been reproduced states all over the country that have prohibited abortion. I think there's 14 now. This language is not medical. And the language in the statutes that govern abortion care in Missouri, which, by the way, it's its own separate chapter of Missouri law, which most states have abortion as a part of the healthcare regulations and healthcare statutes. And so abortion was already over-regulated despite it literally being some of the safest medicine that can be practiced. It is safer to have an abortion at most any point in pregnancy than it is to have routine surgery that people might have, like, their appendix out, their gallbladder out, a colonoscopy, for instance. The fact of the matter is that at any point where someone chooses to end a pregnancy, it is safer than the full-term delivery in terms of risk of blood transfusion, risk of major infection, risk of injury to internal organs, risk of damage to major bodily functions. There are people who choose abortion for all kinds of reasons, but in the state of Missouri now, we can only do them for these life-endangering maternal conditions. We had that process in place at the medical campus because of the process that was required for 72-hour consents. Like I said, it just got rid of the 72-hour consent requirement, right? But we knew this was coming, and we worked with the general counsel of the medical school and the hospital extensively for about 6 months, January through June of 22, to have some written guidance for our physicians to know when we have evidence to support those medical emergencies. And we don't have to go calling the hospital attorneys or the general counsel of the medical school. I know when I can or can't take care of a patient. What I also know is every abortion I do in the state of Missouri, I report to the state. I'm required by state law. And each one of those is being reviewed, and I could be found guilty, or not guilty, I could be charged, with a potential felony offense because the attorney general or some other person in the executive branch believes it wasn't a medical emergency. So that has changed a little bit for me.
Thank you, thank you. Our next questions are for Dr. Jennifer Smith. Dr. Smith is an OBGYN with consultants in women's healthcare and co-founder of Missouri Healthcare Professionals for Reproductive Rights. Welcome. So Dr. Smith, how has your practice changed since Dobbs and through the years as Missouri's abortion policies changed?
You know, like Dave said, it's a lot the same and a little bit different. You know, getting an abortion in Missouri was always a challenge. You know, so many people's insurance doesn't cover abortion. So, you know, if you had a baby with a lethal anomaly, of course, I'd rather have you be cared for by Dave at WashU. Without protesters and all of that, but most people's insurance doesn't cover it. So we were always referring to Planned Parenthood. So now you have to cross the river for Planned Parenthood. The difference is that because WashU is unique in having Dave and his partner, other hospitals are not prepared with what is a medical emergency. And so patients that we could have cared for before who were, you know, days or weeks away from having a worsening medical condition, we could all agree that nothing good was going to happen. Your water's broken at 16 weeks, there's no fluid around the baby, you're having some bleeding and some pain. At some point, you're probably going to either hemorrhage or become septic. We can take care of you. At this point, in our hospital, and therefore, for sure in every other hospital around the state, because we do better than most, nobody knows if they can care for this patient or if they cannot care for this patient. And so these are patients that instead of delivering and creating memories and giving them closure to their very undesired outcomes, we're having to send them away. And, you know, it's panic every time something happens with a patient, this worry of, oh God, okay, what are we gonna do?
Thank you. You already answered the next question.
Good. Tell me what else I can tell you.
Well, I think people would probably be very interested in hearing how this affects you as a provider. Who cares for women day in and day out.
Yeah, I mean, it's really more the anxiety of the whole thing, because we're fortunate in where we live. We live in St. Louis. I know quietly that WashU is taking care of patients who really, really need it. We don't advertise it because I want them to keep doing it, but we're there. I also know that Planned Parenthood and Hope Clinic are right across the river for our patients. And I'm fortunate that most of my patients are able to access that care. They have the financial means, they are socioeconomically advantaged, and I know that they're in a better position than most. You leave St. Louis, it gets far worse. And you leave like my suburban St. Louis practice, it's far worse. But in the last 2 years, the number of women who want to come talk to me about, should I get pregnant? What will happen if I have a problem? Will you take care of me? What happens if I have an ectopic? What if I'm having a miscarriage? What if I have a chromosomal anomaly? Will you save my life instead of the baby's? I have children at home. I need to live for my children. These are the conversations that we are having every day, and these are not conversations that we were having before. Now, patients didn't know how challenging it was in Missouri until they got to that point, and then they were shocked at how difficult it was. But now they know, and women are scared. And frankly, every time my sonographer walks around the corner to come talk to me, I'm bracing myself, like, oh God, is she gonna tell me something terrible? Am I gonna have to, go through this list of options for a patient, one of which, if she chooses, I can't actually provide? So it is incredibly anxiety provoking.
Well, thank you. Thank you for that. Dr. Eisenberg, back to you. Can you speak to some of the ripple effects on medical practice and education and recruitment?
There have been a lot. So WashU has had one of the top medical schools, top OBGYN departments in the country for decades. We've seen a 25% reduction in applicants for our residency program, which is hard to explain other than the fact that this is a state where people think it's either hard to get training or hard to be a person who can become pregnant. We don't have another explanation beyond that. We become more competitive with all the other kind of things that people look for as a training opportunity. That's the only thing that's changed. To make it easier for people to understand, I'll give you two examples. Number one, in light of Senator Shoup's unfortunate COVID diagnosis, which COVID's still happening, but we are 4 years into an experience as a humanity that we learned the world turned upside down in March of 2020, right? When the NBA season ended and all these other things stopped, we all had to figure out what's up, what's down. Did we need to take our scrubs off and take a shower before we went home? Like, how do we diagnose it? How do we prevent it? How do we treat it? 2 years into COVID, think about that spring of 2022. We kind of had a sense of there was a vaccine. We knew when we needed a mask. We knew we needed to stay home when we had a COVID test that was positive. We learned as a society how to live post-COVID. We have learned as OBGYNs how to live post-Dobbs. But people who are getting pregnant now might not have thought about it until they're in the middle of that crisis, right? And so that is a huge change for everyone and anyone who can become pregnant. That's one version of how things have changed. But the other thing I will say is, I mentioned this to some of the folks here while we were having appetizers, is there's a young lady who is a now junior at WashU who I'm friends with her mother. And she grew up in San Francisco. Her mother is an abortion provider in San Francisco. She's a colleague of mine. She nearly chose not to come to WashU in the summer of 2022, having already had an early acceptance, having had a scholarship, because she was worried whether she was going to be able to be in control of her life. Now, she did choose to come, and she's now a volunteer patient escort at Hope Clinic, but not everybody makes that choice. Not everybody has the capacity that you were speaking to in terms of your patients and the resilience to be able to figure out how to move forward.
Thank you. Thank you. And do you want to say a little bit more about the effect of the changes in the laws on lower income populations? It sort of piggybacks on what Jennifer was saying. Are there other specific groups of patients who are more adversely affected by the legislative changes? And what are the most significant barriers these women face in accessing reproductive care?
Is this for me or Dr. Smith?
For you.
Okay. So I'll give you an example from my time when I was the medical director of Planned Parenthood. The laws since I moved here in 2009 have changed. Those screws have tightened on the access to care, such that the law used to be you have to give consent with a qualified health professional, licensed nurse, social worker, physician, nurse practitioner, nurse midwife, 24 hours in advance of your abortion with those state-mandated consent materials. The law changed where it had to be the same physician, no exceptions, 72 hours in advance. And I was sitting in the consult rooms at Planned Parenthood as a provider there at that time, speaking to young people generally less well off than I was, maybe darker skin than I have, having backgrounds that I have no sense of their lived experience. And I couldn't understand why they weren't more outraged by the process that they had to go through to get basic health care, to get the care that they knew was best for them and their family, to choose not to have this pregnancy now so that they could have another pregnancy in the future. Whatever the circumstances were, they weren't outraged the way that I was outraged. And it took me a really long time to figure out, why aren't they? Because by the time they found themselves sitting next to me, going through these consent materials and dealing with the constant, patriarchy and misogyny that is involved in these aggressions that the state has promulgated on them, that is their lived experience. They have come to live that experience in a way that, of course, that's what they need to do to get abortion care. I was like a 40-year-old white guy who never really had to struggle to get what I need in my day-to-day life. And it was that time that I realized, oh my God, this is creating a second class of citizens. The people who can become pregnant do not have the same right to self-determination and agency in this world as the people who can't.
Along that line and continuing that discussion, Dr. Smith, what effect do you think the legislation that has been passed and signed by the governor to defund Planned Parenthood have on Missouri patients if it is not overturned by the courts?
I don't know. Oh my God.
We gave you the questions in advance.
It went to my junk email box. But, right now, Planned Parenthood is functioning in Missouri for testing for sexually transmitted infections and providing contraception and basic health care for women who have no other place to get health care, who are uninsured or underinsured, which is a huge problem in our state for many other reasons. So he's defunding Planned Parenthood because Planned Parenthood sounds like abortion, but we're not doing abortions at Planned Parenthood in Missouri. So it's so frustrating because over and over, if you read the paper, which my husband has told me I should stop doing at times, it just makes you irate because these are things that people are saying, I guess, for political gain, because they don't actually have any real lived impact on people. You just have to spend some time reading what our politicians are saying. They are using women and their fragile right to self-determination at this point and making it even worse for what appears to be political gain. But at this point, Planned Parenthood only receives money for contraception, and never has. The state has never been able to fund abortion at Planned Parenthood, so let's be clear. But Planned Parenthood doesn't do abortions in the state of Missouri, so this is just another attack on women's health in Missouri for a group of women who already are having trouble accessing health care.
And I'll just add real quick. It's been 5 years since I was the medical director of Planned Parenthood, so the data may be a little out of date. But there were about 36,000 patients annually who came to Planned Parenthood health centers in the St. Louis metropolitan area, Springfield and Joplin, for preventative health services, Pap tests, STD testing, treatment, contraceptive care. And men and women, by the way. And the fact is that there aren't enough healthcare providers to take care of that population of folks in St. Louis or beyond in Missouri.
Dr. Smith, also, we all have heard and read that there are many fears and myths and claims about accessing abortion care. For example, it is illegal to access abortion care. It is illegal to help someone access abortion care by crossing state lines. The myth that a heartbeat, in parentheses, can be heard at 6 weeks of pregnancy, indicating fetal viability. And the myth that tests show that the fetus feels pain at 8 weeks. wondered if you could speak to some of those myths and how you manage this with your patients.
So, yeah, I suppose partially, mostly I don't have to. And I guess I don't know why, because they're on the internet and people can access all sorts of misinformation on the internet. But I've cultivated this lovely group of patients, so perhaps that's not what they're accessing. But have had some frank conversations with people when it comes down to the viability issue and that kind of thing. You know, I think it's confusing because states have all sorts of rules, and some states, yes, it is illegal. Well, there are laws trying to make it illegal to cross state lines. And there are laws, say in Texas, around helping people access an abortion. We're fortunate here that that is not the case, and that it is not illegal for me to counsel patients, which I do, and I documented in the records. But for instance, I previously felt like it was ridiculous for a patient to feel shamed about having an abortion put in their medical record. But as I see our politicians poking at, they would like to access this information, they would like to be able to follow people's cycles and whatever else nonsense they say, I realize, like, okay, I'm not worried about protecting myself. I know I'm within my legal rights, but I do worry for these patients that if I put it in there, not that they'll be shamed, because in the hospital, in a medical setting, we understand that this is healthcare, and it is not shameful. It is a decision, and sometimes it's a decision that you make proactively, sometimes reactively, but either way. But I do worry about protecting my patients from what may come down the line from politicians, which is a partial answer to your question. Sorry, but I see the time.
Really wonderful. So for both of you, have you seen many changes in patient behavior, such as delays in seeking care or anxiety about accessing care?
Go ahead.
I mean, I can just say, I've spoken about it and it's been written about, but you know, I had a patient who was in the grocery store and suddenly noticed that her pants were wet. She thought she had been incontinent, which most pregnant women can relate to, and instead she realized it was blood. And she was in her second trimester and she was bleeding through her clothing. And she told her husband, despite knowing that I am not secretly very supportive of women's reproductive rights, despite that, she told her husband he better drive her straight to Illinois because she needed to live for her first child. And she wasn't sure that that would happen here in Missouri. That sums it up in a nutshell. So the patient anxiety is real. And again, I have patients who have access to me, and they do access me all the time. So my patients are less likely to delay care. But this fear that I need to go to Illinois because you can't take care of me, even though I know that you are a supporter, because I have stickers and signs and blah, blah, blah everywhere. You know, even so, that fear that they got to cross state lines to get care, when in general, any complex medical care moves westward. People don't go to Illinois to get health care. People come to St. Louis to get health care. But in pregnancy, they're going in the other direction, and that is scary.
I will say that, you know, inside of our family planning division, we run a Title X family planning center. Planned Parenthood has Title X centers. Title X is a federally funded contraceptive program and sexual health program. It's been around since the 1970s. We take care of a lot of young people, men and women. The rate of people coming in the last 2 years, we saw a bump with the 2016 election, and then we saw it even more so in the summer of 2022, and it has not diminished. The rate of young people choosing long-acting reversible contraceptives like IUDs and implants, where there is a very low rate of failure, and the rate of young people choosing permanent sterilization has gone through the roof, because they do not want the possibility of a pregnancy happening that they cannot choose what happens to that pregnancy.
That's not just in Title X patients. I have done more.
Well, yeah.
I will, just to like equalize the statement. In my suburban St. Louis practice, I have done more tubules, preventive tubules on people who have never had a baby than I have ever done before in these last 2 years.
Look up childless by choice if you're on Reddit or TikTok or Instagram. There's whole kinds of discussion threads. Childless by choice is the tagline.
Well, we thank you both for all the work that you're doing and for sharing your insights and your experiences and being so honest with us tonight. Don't worry, you will hear more from them later on, I'm sure. But please also, to all of you in the audience, if you have questions, please remember to write them down, pass them to the... You okay? Okay. Pass them to the side, and one of the staff folks will pick them up for us. We're now going to move to our rabbinic panel, and I want to welcome all of you tonight. Thank you so much. The first question is going to be asked of all three of you, so I thought I would just say it once. But we're going to ask each rabbi representing different branches of Judaism, Rabbi Arno, the conservative branch, Rabbi Fader, the Reform branch, and Rabbi Smason, the Orthodox branch, to talk about the views of your particular interpretations on women's rights to control their own bodies. What are those beliefs founded upon? And how do these views influence decisions that you make around abortion, IVF, and contraception? It's a very big question. It's a little hard to compress into a minute and a half, I'm sure, but we'll start with Rabbi Arno. Oh, excuse me, Rabbi Arno, who is the rabbi of Kol Rina, for those of you who don't know.
I want to just thank our previous panelists for making me teary a little bit. And I also just want to acknowledge that I'm a man who will never be pregnant. And talking about this, I always have a little trepidation about talking about reproductive rights issues myself as a person who can't be pregnant. And that's what I'm about to do. So I'm not going to get to all of this, but I think for me the thing that lays out the basic thinking about this is a verse or two from Exodus. It's in Exodus chapter 21. This is the Torah, the second book of the Torah. And the situation is if two men are fighting, of course it's men, two men are fighting, and there's a pregnant woman who gets jostled, bumped, whatever, and she miscarries. What happens? And the answer is that the guy who bumped her has to pay a fine. And that tells us two things. One, that the fetus was not considered a full life. This was not murder, because if there's the whole eye for an eye, a tooth for a tooth thing, all right? This is just a fine. And it also tells us that a fetus is not nothing, that a fetus actually does have value. And the rest of Jewish jurisprudence on all of these issues both see a fetus really until it emerges either its head or the rest of its most of its body as not a full human life, and always, even as when you do IVF, what's like an embryo, like an embryo that's why they're here, right? Even a fertilized embryo that's frozen still has value. So somewhere between those two things is where we have to make a lot of really hard decisions.
So I was glad that Rabbi Arno got to go first, because I really just wanted to say ditto, and then I could move it on to Rabbi Smason. But the one thing that really, I think, does distinguish the Reform movement of Judaism from conservative and Orthodox Judaism is, even though I would use the exact same teaching that Rabbi Arno did, one of the things that really defines Reform Judaism is just 3 words, which is choice through knowledge. Because what Reform Judaism believes is when we look at Jewish law, when we look at halakha, we say that it is not binding to us. Instead, we believe that every person is obligated to learn as much about Judaism, as much about Jewish law and history and teaching as possible, and then make an informed choice for ourselves. So Reform Judaism believes really above all in personal autonomy to make our Jewish choices. So even though, again, I agree with what Rabbi Arno said, and that is the Jewish textual basis on which I would talk to someone about abortion, at the end of the day, I also believe that every person gets to make that choice for themselves, and that it should be based on all of the various understandings of Jewish law, starting with the Torah text, and then all of the different teachings in the Talmud and the other books that come after them, but really that each person should be able to make their own decision that is going to have to do not just with their Jewish perspective, but with where they are in their life and with their own health choices. So for me, it always comes back to personal autonomy and choice through knowledge.
Thank you, Rabbi Feder. I failed to really introduce you as the senior rabbi of Congregation Temple Israel, in case anybody here doesn't know that. But thank you. And next we have Rabbi Zev Mason, who's the chairman of Coalition for Jewish Values, Midwestern Regional Vice President. Welcome.
Thank you.
And the floor is yours.
Thank you, Patty. Well, I know it's going to come as a surprise to most of you here that Orthodox Judaism believes a bit differently than what it is that's been said until now. The source of our beliefs are the Torah. We understand that the word Torah means instructions for living. And we understand that although times have changed, the basic values that were expressed in the Torah, which we believe were divinely given, those values haven't changed. Regarding the right of a person to their body, be it a man or a woman, we understand that we are stewards of the body that the Almighty has given us. Much like in the same way that for those of us who are blessed to be parents, we understand that we don't own our children, but we are caretakers of our children. Similarly, we are given our bodies by God to be able to use as tools to be able to accomplish the things that we seek to accomplish in life. So we have obligations to be able to take care of our body that are divinely mandated, such as it's a mitzvah to exercise. Similarly, it's a mitzvah not to harm oneself or not to get a tattoo, just as examples. Excuse me. Regarding abortion, the Torah tells us that the ensoulment of a child takes place at the moment of conception. So from that point onward, we look at life as having begun from that moment. And an abortion would be permitted when there would be either a danger to a woman, either physically or psychologically. I think part of the question that I'm to answer as well is how I deal with questions that are presented to me. Was that part of the question?
If you can, sure.
When I look at myself as a GP, not a specialist, and there are a lot of different areas, including medical situations that are far beyond my pay scale. So I have a Rolodex of doctors that I ask questions to, of rabbis with long beards that I ask questions to, and based upon their knowledge of medicine and of religion, those questions are answered when those complexities present themselves.
Thank you. And for each of you, another two-part question. Within each of these different systems of belief, there are likely to be gray areas. And how do you decide and act within those areas? Clearly, there are scientific and technological advances that didn't exist 3,000 years ago. So how are or how should decisions be made?
So, you know, I think one of the amazing things about Jewish tradition is that in none of the branches of Judaism do we believe that our teachings stop with Torah. And it doesn't stop with the Talmud or the Shulchan Aruch or at any point down the line. And in fact, to this very day, if you have a Jewish question and you go to your rabbi and he or she cannot answer it, then there is a process for how to do that, and this is the responsum process. And so what happens is someone will ask a question, and then, at least this is the way it works within the Reform movement, it goes to a group of rabbis who sometimes spend years trying to look at all of the texts and all of the history in figuring out what the answer is. And by the way, it's all online. So you can go right now and you can say, what does the Reform movement think about what happens if someone thinks they need to have an abortion, and not only do they believe that they may be emotionally affected by it, but their children may be, or their spouse may be. And there is a responsum that is about that exact thing. Now, what that means is that all of these different rabbis have gotten together to try and find different historical and textual answers to that, and then they will present you with an idea so you can make a decision for yourself. But still, the idea is out there that says, no one is basing decisions just on that 3,000-year-old teaching from the Torah. That may be where we start our discussion, but these conversations are happening within Jewish circles, I believe within all of our movements to this very day, because we know that life is changing and medicine is changing and our roles in this world are changing, and that we have to keep asking those questions that someone might not have even known could be a question 10 or 15 years ago.
Rabbi Spason, did you want to?
There's, much like perhaps in the American Constitution, there are certain principles, and those principles are applied to modern technology, medicine, and science. So too with the Torah, those basic principles are extant and they're applied to modern situations. I'll share with you an example. A great halachic decider, a prominent rabbi of the late 20th century, Rabbi Moshe Feinstein, was once asked what the most difficult question was that he ever had to deal with. And he responded that he was once presented with a case where there were co-joined twins, and the question was whether, given that in the situation one of them would die if they were separated, whether that was permissible according to Jewish law. So he said that he consulted with the physicians with whom the family was working, and he essentially isolated himself for 3 days, going through primary Torah texts to be able to deduce the principles, and then on the basis of that, he decided that he rendered his decision, which in that case it was permissible, and the child lived. So whether it be patent law, intellectual property, whether it be erasing God's name on a tape recorder, technology presents all types of interesting questions, but what we do is we look to the principles, if we're capable ourselves, or we look in our Rolodex or the modern equivalent to be able to find individuals who are knowledgeable both in the medical area as well as in the religious area. And I'll just conclude my response by quoting or citing Maimonides, the Rambam, who says that if a person says that there's a conflict between science and Torah, Maimonides says they either don't know enough Torah, or they don't know enough science, or they don't know enough of either.
Rabbi Arno, did you want to weigh in? Yes.
Sure. So you asked about gray areas, and the bottom line is, yeah, there are lots of halachic gray areas, but they sort of don't matter, because in the end, each person is going to have to make decisions for themselves. And the conservative movement strongly believes that there should be the legal options available for everybody to be able to do that. And the guiding principle is actually a verse. It comes from the Talmud, but there's a verse from Proverbs, which obviously we all know by heart, right? Yeah, no. But you sort of do. The phrase is Lev Yodea Marat Nafsho. The heart knows the bitterness of the soul. Each person knows what it is that really is painful for them, and nobody can quantify anybody else's pain. And for one person saying, all right, maybe I don't want to have an abortion. And for another person in the same situation, they might say, I'm having an abortion. And only a person knows themselves well enough to make that decision. My role as a rabbi is not to tell people have an abortion. Don't have an abortion. You need to have more children. No. My role is to help them figure out what the right decision is for them. And if they have questions and want to know what Jewish views on these things are, the bottom line is there's a huge amount of gray area, and they are the only ones who can actually answer this for themselves. Which is not to say that everybody has complete bodily autonomy. I agree with Rabbi Smason in that sense. And at the same time, the only one who can actually decide where those boundaries are for each of us in so many cases is ourselves.
In case you didn't think things were complicated enough, I'm reminded as the three of you spoke that this is also what defines Judaism. Questioning, discussion, disagreeing, more discussion. And we have almost 200 people here tonight, so that's 200 Jews, and that's a lot of opinions. But it's extremely interesting to hear you all focus in on this. Another question that's come up is, do you find that congregants are bringing different kinds of concerns to you as their rabbis? What are their spiritual concerns about this? And has your counseling then changed over time? You already started to answer that by saying not really. But I wonder if you all have some thoughts about that.
Also, just say one thing. I'm grateful to the NCJW for running a cohort for clergy around counseling around reproductive rights issues. It was a national cohort, but I heard about it from the local NCJW folks here. So that was really helpful.
So I've been a rabbi in St. Louis for 18 years, and the first thing that I did when I started was I joined this organization called the Missouri Coalition for Reproductive Choice. It was like the worst acronym ever. Now it's called Faith Aloud, which is much easier to say. But what I was doing was I signed up to be a counselor for anyone who was Jewish who wanted to ask a question, have counseling around abortion. And it's been 18 years, and I have talked to fewer than 5 people about it. And I'm not entirely sure why that is. But I will say, and this is not just for my own congregation, this is anyone that was, that reached out to this organization to find a rabbi to talk to about abortion. 5 people is not very much. And so I don't know if, it's similar to Dr. Smith, if I've just sort of, my clientele, this is not something that they're asking about. It's not because they're not having abortions, though. It is simply that when they're making their decisions, they are not looking at Judaism as being the factor that they are so concerned about that they need to have my blessing or my guidance. And again, maybe it's because they already know what I think about it, but it has simply not been something that has really been a part of my counseling.
Rabbi Mason,
Haven't been asked often as a rabbi about abortions and related issues, although when it has come up, I find that over a period of time, people are very interested in wanting to understand the why rather than the what. And I think that applies across the board. People are more sensitive to the sentiment that they feel that while Judaism does and synagogues do religion real well, but sometimes the spirituality is missing. And the relevance and the understanding of why we do the things that we do and why we believe the things that we do, that's also something that's absent. I liken the rituals that are followed by individuals without understanding them, whether it be in this area that we're discussing or others, to an individual who might come to a synagogue, and a synagogue where the services are all in Hebrew, and a person isn't familiar with Hebrew. For that person, it's a bit like walking into a movie in Portuguese without subtitles. And today we're dealing with individuals who are highly educated, and they want to have a meaningful, spiritual, connective experience in understanding the issues that we're discussing, or Judaism in general, and that's been absent in the past. I know, speaking for myself, having not grown up Orthodox, when I went to Hebrew school, I walked away for many years knowing only 2 words in Hebrew. Sheket bavakasha. Or you could say 3 words, hey. So people want to understand the whys, they want to connect with God, and they want to have a spiritual experience in an understanding of why would they do the things that they do.
That meant quiet, please.
I don't know how to thank you enough, but on behalf of all of us here, thank you for all the work that you all do in the community as well. We do have some audience questions, and let me read them, and then I'll read them to you. So for the rabbis, please discuss where or how much of your training was spent on reproductive health care issues.
So I will share it just really because it's a personal story, but it's one that I know have permission to share. So in my rabbinical school class, 2 of our classmates who were a married clergy couple, they were married, they had a child, and then became pregnant again. And during the second trimester of my dear friend's pregnancy, they found out that there were terrible health complications, and that if they were to bring the pregnancy to term, that if the child lived out of the womb at all, it would be very short and horrifically painful. And because our rabbinical school class was very small and we were all very dear friends, we all sort of became a part of this terrible loss and tragedy together. And they ended up going and they saw Dr. Tiller of blessed memory, who you may have heard of before, who was one of the few people who provided that kind of abortion care and who was murdered. And because of that, I spent a lot of time studying and talking and learning about reproductive choice and about abortion, because we all, as rabbinical school classmates, went through this experience with our dear friends who were married and who were parents and who longed to be parents to more children, and who were faced with this impossible choice of a life who we already knew what this child was going to be named, and already felt like he was a part of our little family of rabbinical students. So because of that, I would say we spent a lot of time talking about these issues.
Interesting.
Certainly in my rabbinic training, we reviewed the basic textual sources, such as Rabbi Arno mentioned, various Talmudic sources that discussed the issues in a very broad way, but perhaps much like in the same way that a resident has general training but isn't quite prepared to operate on a patient, a newly minted rabbi isn't prepared to render a decision, certainly when something involves a question of life or death. To the degree that I can say that I have knowledge in this area is really based on a few experiences that we've had personally within our family. We've been blessed with a child who has Down syndrome, and we had a child who died shortly after my wife gave birth. So that was an opportunity to investigate the issues from a halachic, from a Torah perspective, and then it became real, and I think that all of us can relate to the idea that we can understand something on an academic level, but when it touches us personally, so then we really begin to dig into it and to ask the why and to seek to understand. I'll also just conclude by saying that my understanding of the issues in general has been informed by the blessings that we've been given of having a family and our children as well. We've been blessed with a large family, and just a quick anecdote. I remember one time my wife was expecting our 6th child, and I got a pager. Anyone remember pagers? So I went to get a pager when she was in her 9th month, and the woman who was behind the counter, she was obviously not Jewish, and we were chatting, and she said, asking me why I was getting the pager. I said, well, my wife was in her 9th month. She said, are you expecting your 1st? And I said, well, no, actually, we're expecting our 6th. And her eyes got real wide, and she said, are you Catholic? So life is the best teacher.
Thank you. Rabbi Arno, did you want to weigh in?
Didn't learn much, but I learned how to read. And I mean, like, read in a Jewish sense, for which I'm really grateful.
Thank you. So this question is for the doctors. Hold on a minute. Can you speak about IVF and current proposed legislation at the state or federal levels and how these laws may impact clinical practice?
So I would tell you I'm not sure what Missouri has out there. I think there are some lawsuits that could end up defining Missouri law if we do not pass this ballot initiative in November. So currently what we have on the books, as soon as the trigger ban happened in Missouri, all of us who were OBGYNs knew that IVF was at risk. There's nothing about our trigger ban that protects IVF, and all it takes is a lawsuit like that in Alabama to prove that point. So currently, all is well, but I think we should not be comfortable to sit back. I think Alabama taught us that. I think the federal government's refusal to codify a woman's right to IVF is warning. And I think, I firmly believe that come November, we need to get out and we need to get every person we know to get out there and vote to codify our rights to self-determination, which would include IVF, because there is no telling what will come next. And right now we have no protection except for the fact that there hasn't been a legal opinion to tell us we can't.
I'll add, the fact is that medical care and the definitions that govern medical care are state to state. There is no federal guidelines around these kinds of things. So the definition of what an induced abortion is in the state of Missouri is different than it is in other states. I know it off the top of my head. That is the intentional destruction of medicine administered to or instrumentation to remove an embryo, fetus, etc. They use the term unborn child from a mother's womb. It's non-medical terms. It's past legislative statutory language. But how that gets interpreted is really important, because there is another clause in there that says, other than to increase the likelihood of a live birth. So those people who are choosing to reduce quadruplets or triplets down to twins are doing it with the intent to increase the likelihood of a live birth. That isn't an abortion in the state of Missouri. It has to be in a mother's womb is the language. So ectopic pregnancies, regardless of whether there is fetal cardiac activity, are not in the endometrial cavity. That's the medical term for the part of the uterus where the pregnancy is supposed to be. If it's ectopic, we can still take care of them in the state of Missouri. But language matters. When the spring of 2019 legislative session passed this omnibus abortion bill that included the trigger ban that went into effect on June 24th, 2022, it removed two words from that definition. The intentional destruction of and medication administered, et cetera, other than to increase the likelihood of a live birth or to remove a dead or dying fetus was the language, or dead or dying unborn child was the language in the law. Or dying was removed from the legal definition of abortion in the state of Missouri in 2019. So people who practice in Missouri taking care of people who are pregnant in a person who the pregnancy is on its way out the door, when there's cardiac activity there, are doing an induced abortion in the state of Missouri. So by definition, when I see a patient who's in the midst of a pregnancy loss, they're bleeding, the water is broken, fetal tissue, the umbilical cord might be hanging in their vagina. If there's fetal cardiac activity, I have to go through that state mandated consent with them. They have to initial 13 lines on that consent, and then I certify that it's a medical emergency before I can take care of them. That has been the way we've been doing it since 2019. That is a pregnancy that is only going to result in someone bleeding till they need a transfusion, bleeding to death, having an infection. Nothing good will come of that pregnancy loss. And me having to go through that paperwork with these patients, having the worst possible day of their life, has been brutal. And it is not going to change until we pass a law like that one. Until the federal government recognizes that the people who can get pregnant in this country are equal citizens and have a right to decide what happens to their bodies. And so the law matters. And there is no law protecting whether you can or can't have a pregnancy, whether you can or can't have an IVF pregnancy, whether you can or can't access contraceptive care. If you think birth control is safe, you are wrong. It is all about controlling people's bodies who can become pregnant. And until those people who only 100 years ago got the right to vote are in greater numbers voting for themselves and greater numbers writing the laws that govern us, we are going to have to keep fighting. And even then, we probably will have to keep fighting.
This question came from an audience. The last few questions have all come from our audience, so I thank you. I didn't recognize you before. This next question reads as follows. I'm concerned about women in rural Missouri dying because of lack of obstetricians in hospitals closing because of the abortion ban. Has the death rate of women increased?
So it's actually a little too early to say. So vital statistics take a few years to be collected and be analyzed, et cetera. But my colleagues and I, my fellows, have done some research to show that from 1999 to 2019, which was the last time we had enough data, that during that period of time, 1999 to 2019, it was a 20-year period, states that had prohibited or severely restricted access to abortion care had a 4-fold higher rate of maternal mortality. Now, that isn't just because of restricted abortion access. It is because those are the same states that are likely to prohibit universal contraceptive coverage, universal sex education, ensure that people have access to basic healthcare services. That constellation of anti-science belief systems, what Phil Needleman, those of you who knew him and what a wonderful scientist he was, he would talk about the endarkenment. The idea that we had the period of enlightenment where we embraced science as a way to improve the health and well-being of humanity. We are now in a time, in my opinion, that there are some people who want to go back on that. And if you are not able to identify those threats, then you are going to be victim to the things that come as a result. We all have to be engaged.
I would also add that before our ban, I believe, I could be wrong, it's either 42nd or 44th out of 50 in maternal mortality. So you should be afraid for rural Missourians because it was already bad.
Yeah, and we know that increasing access to preventative health services like contraceptive care, PAP testing, STD treatment, testing, et cetera, improves the overall health and well-being of society. When you look at the interventions, I'm a public health guy, right? When you look at the interventions to improve the health and well-being of society, investing in clean water systems, we've seen the results of when that fails and lead poisoning, et cetera, right? Vaccination programs, not the vaccines, but the ability to make sure that people get their scheduled vaccines correctly, and family planning. For every dollar spent on a family planning program at a public level, you will save $8 in future healthcare costs over 5 years. It's not about the economics, it's not about the finances, it's about misogyny, unfortunately. So that's the reality of the world.
I'm standing here trying to think, how can we end this on what feels like a more hopeful note? But the whole purpose of tonight was really to share very painful, very difficult, and very controversial information with a large group of our community. I think we have time for one more question. Yes? We okay? One more? I'm getting the signal from up here. you started to talk about this, Dr. Eisenberg, earlier, about the ripple effects on residency training. Are there downstream implications of training fewer providers in other medical fields besides OBGYN for Missouri residents?
I mean, if we don't have an adequate healthcare workforce, it's going to be really hard to have a healthy population. And so over half of medical school graduates are female. That has been for over 10 years, I think. And if they're choosing to not practice and do their training in places where they might not have control over their bodies, then they're not likely to practice in those locations. People who complete their residency training are more likely to stay in those regions, whether it's as a pediatrician, as an emergency medicine physician, as a radiologist, or as an OBGYN, whatever it is. And if we are not a state that is welcoming to over half of the med school graduates, it's going to be real hard to have an adequate healthcare workforce.
Thank you. I'm afraid I have to bring this to a close.
Can I give the positive light?
Please.
So I moved here in 2009. I moved here hoping to be a part of moving the needle towards improving access, improving health outcomes. And sadly, we've backtracked, right? But there is something happening in the last 2 years where people have realized, well, first of all, Roe wasn't enough, but that it was fragile, right? We had opportunities to codify the right to choose what happens to your body, the right to access contraceptive care, the right to build a family how you want with IVF and with whom you want, right? But we have missed those opportunities on the political stage, federally and at the state level, because people didn't think it was really going to happen. Well, it's happened. So here's our opportunity to fix the world, right? And make better choices about policies and politics. It's not easy. It takes time. What the state of Illinois did in 2019 while the state of Missouri was going the other direction was a 25 to 30-year process to pass the Reproductive Health Act that allows me to take care of so many Missourians, Louisianans, Mississippians, Alabamians, Texans, Arkansans, from all over, because I can go to Hope Clinic in Illinois because it says in state law that the person who is pregnant is the only one who decides whether to continue or whether not to continue that pregnancy. We can do that in other states. We have an opportunity to do that this year. Let's not miss out on it.
So as we come to a close, we know, at least I'm confident, that you found the panel discussion to be very informative and very thought-provoking. As with many things Jewish, we imagine you will leave with many more questions, which should create more discussion opportunities with those around you. It is my pleasure now to invite Denise and Brad up for some closing remarks.
Thank you, Patty, for pinch hitting. That was great. Jill was very passionate about this topic, and she's worked very hard in her career towards this end. But I think Patty was a great understudy, as you said. And thank you for our panelists, Dr. David Eisenberg, Dr. Jennifer Smith, Rabbi Arno, Rabbi Feder, and Rabbi Smason. Thank you very much for your time. We mentioned at the beginning that all of this is made possible by our annual campaign. At Jewish Federation, one of our core commitments is to secure the well-being and the safety of individuals within the Jewish community and actually within the whole community. One of the ways we do this is through our investment in Jewish Family Service, which is called JFS. That's one of the places that Jewish Federation helps fund. JFS has over 150 years of experience providing services to clients ranging from children to older adults that are facing complex challenges. They offer information, referral, and when appropriate, counseling in a respectful, kind manner to people around issues of reproductive concerns including relationship changes, unplanned pregnancies, adoption and abortion, pregnancy loss, traumatic deliveries, etc. All of this is assisted by Federation dollars. Professional Society engages Federation's donors by presenting programs of interest, such as this one, to its members and guests. We are so glad you were able to join us tonight and leave here, as Patty said, with some answers and possibly many more thought-provoking questions. Thank you very much, Patty, and thank you, Sarah, for all of your help putting this wonderful event together. Thank you.
And Denise, thank you for leading these efforts as our vice chair for the healthcare division, along with Lisa Hirschberg, the new professional who supports the professional societies, and Stacy Wagerman, the senior director of women's philanthropy and affinity groups. Our next professional society event will be led by our business and real estate division and will take place on September 12th. Later this year, we will also host a special professional societies donor appreciation event, which includes a tour, and it will be held at the new soccer stadium. So look for more information to arrive in your inboxes on that. And this concludes our formal program, but we invite you to stay around, enjoy drinks and dessert. As Patty shared, our panelists will also try to stay around to talk and answer any questions. On behalf of the professional societies and the healthcare division, thank you for joining us and have a great evening.